Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of choroid plexus carcinoma. So this is a 1-year-old boy who presented with enlarged head noted by the parents, and this is actually the typical presentation. And as you can see here from the low power magnification, there is this vague papillary growth pattern, but what is really eye-catching is the pleomorphism, and this is extremely important in rendering the diagnosis. So on high power magnification, we can see here the papillae and those then gigantic large cells with hyperchromasia, marked pleomorphism, intranuclear inclusions. Another field showing somehow the vagueness of the papillary architecture, but what is really eye-catching is the marked pleomorphism that we can see here, as well as the intranuclear inclusions. And then we move to other areas where we have total loss of the papillary growth pattern, but yet retention of the pleomorphism. And then we start to see scattered mitotic figures here and there. And another focus again with gigantic cell, with a mitotic activity, with hyperchromasia, again, another pleomorphic nucleus. These are very important features to render the diagnosis of choroid plexus carcinoma, which should be suspected once we see this combination of the vagueness of the papillary growth pattern, the marked pleomorphism, the intranuclear inclusion, the presence of mitoses. Other areas show this combination where we have some perivascular pseudo rosettes, and then we have the markedly pleomorphic tumor, and this is repeated again in another focus. And why I really wanted to show you this focus in particular, because if this is seen alone, one of the differential diagnoses that might come to mind is whether this is yolk sac tumor or not, because there is some resemblance to Schiller-Duval bodies. This is why this is an important differential diagnosis. Yolk sac tumor is an important differential diagnosis to choroid plexus carcinoma. Other important differential diagnoses are ependymomas, although this is not usually as atypical as this tumor and not as pleomorphic as this tumor. Also very important to keep in mind one important differential diagnosis, especially in young age group in infants. And remember, the boy is 1 year old, is atypical teratoid rhabdoid tumor. So these are the three main differential diagnoses that we should keep in mind once we encounter a case in which we suspect choroid plexus carcinoma. And then we have the pancytokeratin. And sometimes the pancytokeratin can show only this focal strong positivity. This would not really rule out the diagnosis. What is important to remember is that EMA or EMA is usually completely negative. Now, this is very helpful in our differential diagnosis because ependymoma would show the dot-like cytoplasmic staining, and atypical teratoid rhabdoid tumor would typically show EMA positivity with or without cytokeratin positivity. So a negative EMA staining, which is typical of choroid plexus carcinoma, would support the diagnosis of CPC, choroid plexus carcinoma, but rules out the diagnosis of ependymoma or an atypical teratoid rhabdoid tumor. And then transthyretin, very helpful stain, granular cytoplasmic positivity, even the cytoplasmic intranuclear inclusion, because the origin of the inclusion is the cytoplasm, it takes the stain. So this staining is very supportive that the tumor is a choroid plexus carcinoma. Remember, choroid plexus carcinoma can show synaptophysin positivity, but it's typically completely negative with the chromogranin A, and can show some GFAP positivity, scattered cells, that does not make it into a glial tumor or ependymoma. Now, as I told you, since we have to think of yolk sac tumor, we have to do SAL4, and this is completely negative, thus ruling out yolk sac tumor. And this mark B1, INI1, should always also be done because we have always to think of atypical teratoid rhabdoid tumor, and that there is retention of the nuclear stain, which means that this is not atypical teratoid rhabdoid tumor. What is really important once you suspect a CPC, choroid plexus carcinoma, is to do P53 because number one, it supports the diagnosis. This is a strong nuclear staining in 80% of it or more of a tumor cell nuclei. So this positivity tends to support the diagnosis, number one. And number two, because the large number of CPCs are associated with germline mutation with P53 in association with Lofromani syndrome. And this was actually the case. The boy was tested for germline mutation for P53 and turned out to be positive, thus supporting the diagnosis of Lofromani syndrome with all the implications on the patient as well as on the family. Ki-67, I have to say, was not markedly increased. It was like 3 to 4%, as were the mitotic figures, the mitotic activity in this tumor, but this does not rule out the diagnosis. So the final diagnosis in this case is choroid plexus carcinoma, CNS WHO grade 3. Remember that once we encounter a papillary tumor growing in the ventricle with this marked pleomorphism, you have to think of choroid plexus carcinoma. Remember that the most important differential diagnoses are ependymoma as well as yolk sac tumor and atypical teratoid rhabdoid tumor, for which we all have immunohistochemistry to support the diagnosis. Remember, with choroid plexus carcinoma, you have to evaluate the pleomorphism, the sheeting, and the loss of the papillary growth pattern that is usually a feature of the lower grade tumor, whether this is the benign or the atypical choroid plexus papilloma, in addition to the marked pleomorphism, which is extremely important feature to support the diagnosis of choroid plexus carcinoma, in addition to mitoses and necrosis. And remember, once you render a diagnosis of choroid plexus carcinoma, you have to support the diagnosis with P53 immunohistochemistry and then germline mutation to look for the presence of or absence of Lofromani syndrome, which would have an implication on the patient as well as on the family. I hope you find this tip useful in your daily practice. Thank you.